Hello everyone, and welcome to our session today, the top 5 financial mistakes new managers make. Our presenter is Nicole Nash-Arnold, Nurse Manager HQ. Nicole Nash-Arnold is a nursing career coach who helps great nurses transform into respected leaders. She shares her 15 years of experience in both senior and executive health leadership roles to germinate great leadership. Clinically, Nicole has over 10 years perioperative experience before moving into her nurse educator and management roles. Currently, she manages a privately owned emergency department in Brisbane. Nicole has postgraduate qualifications in perioperative nursing and currently a Master's in Nursing. Nicole is a member of the International Coaches Federation. Nicole, welcome to the microphone.
Thanks very much for that, Sue. Yeah, today I'm going to go through the top 5 money mistakes that nurses make, and it's often new nurse managers to which that I refer when I talk about this, but it's also senior clinical nurses that are stepping up into new nurse manager roles, or they're acting in the role, or even they're fulfilling their clinical role for the most part, but taking on some of the responsibilities of that side of the health service and are starting to gain some exposure to this side of their clinical environment and the non-clinical parts, such as the financial part. And it often causes a great degree of conflict for nurses once they're newly exposed to this side. And the fundamental problem, I think, is that for nurses, when they arrive in this scene, in this space of our profession, they feel that business and healthcare is an awkward mix. And business might mean government, and it might mean not-for-profit sector, and it might be for the profit sector. But nevertheless, there's this fundamental conflict that sits with them, that sits in the back of their head and feels like this business and this healthcare is a bit of an awkward mix. They don't often align, and there's some purity in the core clinical work that you do, that you can do the absolute best for the patient that sits in front of you and nothing else matters. But somehow when you move into the broader context and you have a bit of more a helicopter view with things, then you realise there's a few more elements to this scene and this space than otherwise realised, and that can be a fundamental conflict with your values for a registered nurse who is very committed to being a patient advocate, and you feel often that it's less about patient advocacy and more about financial imperatives. And those values can be very, very compromised, and it feels like you're selling out. It feels like if you're a nurse manager and you're making this transition to become what is expected or what you perceive needs to happen, means that you become a company girl or a yes man. And there you feel like you have to disconnect from that patient advocacy, that core patient advocacy above everything else, and align those values elsewhere. So these are the sorts of things we're going to talk about why that fundamental premise of a disconnect from patient advocacy and a reconnect with a business and healthcare is an awkward mix can be a very happy marriage for a lot of the time, and that there are fundamentally 5 mistakes that thought exposes, but we're going to debunk some of those myths, and we're going to have a look at why you need to stop fearing the business side, what that can offer you, and see it as a wealth of potential once you embrace that it truly is, that is perfectly aligned with your patient advocacy. So mistake number 1. There's a fundamental premise about this part of our role, which is no margin, no mission. And really what that means is that what gets measured gets managed. What you do in terms of margin drives the mission. So when you've got a good, healthy base, financial base from which to work on, then you can look after as many patients in whatever way that you want to for ever, for as long as you're there to be able to do it. But money makes the world go round, and without it, we can't make them pay for the human resources that we need, and we can't pay for the material resources that we need to drive that business. So there is a financial imperative. There is, in OECD countries, there isn't a way that people are doing pro bono work and missionary work. It is fundamentally, in a developed country, something that we need money to fund it. And so there has to be, if you want to make your patient advocacy number one, then first, well, not necessarily first, but equally, you need to make sure that the money is taken care of. And there are key financial indicators that go with that. And a lot of nurses feel quite intimidated when they turn up and they're asked to calculate the work hours per patient day, because it isn't something it seems patient related and is just a financially related thing. But the fact is that calculating work hours per patient day is easier than calculating a heparin infusion. It's far easier than setting up a PCA, and the actual formula is easier than calculating a BMI. And it has incredible power. If you manipulate those two numbers, it just is calculated by the number of nurses that you have and the number of patients that you have in a hospital. That is, if you can manipulate those numbers, the hours that you can flood your ward with and flood your health service with, or wherever the setting that you work with, is amazing. But you have to be able to manipulate those numbers well. So that's what I mean when I say there's no margin, there's no mission. If you can manipulate the numbers to your advantage, there's untold wealth there for you to be able to get for your patients. There's a great article by a CEO, a nurse CEO in America, about her journey from being a PICU nurse, and then she was an after-hours coordinator for some time. And then after her children got a bit older, she started to find herself in promotion after promotion. Then all of a sudden she found herself as the CEO of 3 of the very, very large not-for-profit tertiary referral hospitals in America. So this PICU nurse comes from bedside to boardroom and is the CEO. And it's a great article because it talks about why nurses are perfectly positioned to be leaders in this forum. So she has the view that nurses are incredibly balanced and they're incredibly resilient, and they can deal with pressure really, really well. And they're used to dealing with outcomes, and they're used to dealing with being constrained by regulations. We do that every single day of our life, where we deliver care within the workplace health and safety guidelines, within policy and procedure, with the standards that we're required to set. This is just one more constraint that we've not needed to have before, that we need to start thinking about now. One of her great quotes in the article is this: margin sustains mission. Understanding that and scrutinising clinical care and outcomes is as important as financial statements and performance. Your internal metrics must support you in questioning your assumptions and gaining a true picture of performance. It just summarises so well about why nurses are perfectly positioned to be able to think in this manner. As they're already thinking that way, it's just one more thing that they need to think about. So mistake number 2 is thinking that money isn't important to organisations as it is to the individual. Really, money for everybody is about freedom. In another conversations that I have with people, I often have conversations with them as a coach about what's important to them in their personal fundamental foundation. One of the things they often talk about is money, and how important that would be to them to be free from money problems. And usually when I say to them, what does that look like? What does that feel like? And they say, freedom. They use different words for it, but fundamentally it means freedom. So if we take a step back from what the organisation looks like and just sit in your shoes and what money means to you and the impact that it has on your lifestyle, we can assume that there are 10 fundamental foundational factors, tick boxes, a checklist of what makes you as an individual feel like you're free from money worries. I'm going to go through what those 10 things are, and then we're going to look at them as what they might look like if you're an organisation. So as an individual, if you want to be free from money problems, then you currently save 10% of your income. You pay your bills on time. Your income source is stable and it's predictable. You make good on money that you've borrowed. You have 6 months of living expenses stored away. You live on a budget that allows you to save and not suffer. You live well within your means. Your assets are insured. Your investments don't keep you up at night, and you know how much you're worth. That's the top 10 checklist for what you are required to achieve to feel like you have financially independent and that you're free. It's certainly not rich, and it's certainly not that you've won the lotto. It's just that you feel not burdened by money. If we have a look at what an organisation might look like, they're exactly the same. There's no difference to how an organisation feels about it as you do as an individual. So if you look at those top 10 but make it about an organisation, then they have a 10% reserve on what their revenue is versus their outgoings. They pay their bills on time, and their bills, which is 90% of a hospital or any health service outgoings, are human resources. It's an enormous expense to the organisation. And a very distant second is medical expenses. So they have the same pressures that you do in your household budget. It's just they're different things. They're human resources and material resources. The income source is stable and it's predictable, so that they have patients in their beds on Friday night through to every single day of the week, and it's not occupancy that looks like 2 patients tonight and 29 tomorrow, and that makes it difficult to manage, and they don't know where their revenue is sitting. They've made good on the money that they've borrowed. The equipment that hospitals buy is absolutely enormous, and they may take loans just like you do on your car, but it happens to be on a much bigger scale for different things. But still, they borrowed money and they need to repay it. They've got 6 months living expenses stored away. Organisations want to have a reserve just like anybody else does. They live on a budget that allows them to save and not suffer. Just like us, they don't want to be sitting there thinking when the next paycheck is coming in and whether they're going to make ends meet. They want to be able to have a little bit of a buffer. Live within their means. Their assets are well insured. Their investments don't keep them up at night. And honestly, when a hospital or health service is poorly performing, it keeps them up at night just like money keeps us up at night when we're worried about paying a mortgage because interest rates have gone up. They worry about it just as much, and they know what they're worth. So they're the sorts of things that are exactly the same. I saw an article on the internet recently about an individual who had achieved financial independence, and he was asked what it felt like. He was free from money worries, and he said there was some, other than the fact that he had cash in the bank and he didn't have to worry about it, he said, my health improved. I no longer was afraid of being made redundant. Accomplishments, oddly, were actually heaps easier. He gained heaps of confidence. He was less afraid of failure. He was able to stand up for what was right without fear of consequence about what would happen with his job. He cared less about what people think, and he actually started to appreciate the government. If you were in a situation where you were working for a hospital and you were making financial decisions for the ward and not necessarily just being a patient advocate for the patients that you were looking for, wouldn't you like to work for an organisation that felt like that, like felt independent from financial worries, and that they had gained confidence, they were not afraid of failure anymore, they were no longer being afraid of what was looming in the industry, they appreciated governance for what it could be, which was to get great outcomes for their patient because they weren't worried about money. That's the power of when you embrace money and embrace what you can do, and if you embrace that part of it, what it can make you, it let you achieve in your healthcare environment. Sometimes the money's got to come first, and money is freedom. It's not the burden that a lot of nurse managers think that it is, and it's as important to organisations as it is to everybody else. The third mistake is not recognising that cost is an essential part of delivering essential patient outcomes. So I'm going to give you an analogy. The fire triangle. To start a fire, you need 3 fundamental elements. you need oxygen, you need heat, and you need fuel. There's no doubt about it. There's no arguing about it. But if it's this fire, then that. You don't need one of those two elements. No oxygen, no fire is going to happen. No fuel, no heat. It's just not going to happen. And all of the fire retardant devices that we have either kill off one of those three fire elements so that you can kill the fire. In fact, managing is much the same way, and there are three elements to being a great manager and having a great environment and a great culture and a great health service delivery. And they're the project management principles. There are three elements to it: quality, time, and cost. If you're running a project, and essentially that's what you're doing, your project or your service is taking X patients and taking them on a journey in whatever way that you do. That might be in the community sector, it might be in the acute care, might be in primary health. But you have a project where for X period of time, then you're going to deliver that project. And these three elements are fundamentally essential to delivering an excellent, excellent project, an excellent, excellent health service. And without one of them, the other two don't work. Then there's no project, just like with a fire. So quality is easy for us. We are quality individuals in terms of what we do in our core business. Nurses love quality. They are incredibly committed to delivering quality outcomes for their patients. So that comes naturally. And so does managing time. Our ability to manage time is something we learn day one as graduates, and at university when we're coming through, that's what we talk about is, how you're going to manage your time. You've got 4 patients, you've got 5 patients, you've got 1 ICU ventilated patient, you've got a caseload in the community of this number, you have to manage your time. So we are incredibly skilled. Cost is the same. If you want a quality project, then you have to consider this triangle and embrace it. Otherwise, it just won't work. You can't just focus on quality and time. To give you another analogy, I'm not sure if you've ever seen the British program Grand Designs, and there's the similar version on Australia as well, Grand Designs Australia. And they showcase epically beautiful homes that are designed by architects and then executed. And some of them are very modest, but they're always spectacular in how innovative and how great they are. And sometimes they're $100,000 and sometimes they're untold millions. But the very premise of what an architect does and what project managers do in this space is this project management cycle. So they want a quality product and they want an excellent, beautiful space and a building that represents whoever the client is. They have to deliver it on time. People can't just live in their rented apartment while time gets out of control, and everyone's got a budget. They've got 100,000 or they've got untold millions, but they never have an unending number of millions. It might be an epic amount of money to us, but it's $5 million for their renovation and they build to that $5 million. And the same thing applies. I mean, architects have the exact same struggles that nurses do in that they feel to compromise the quality means that you've compromised the whole project. But everyone's got time constraints, everyone's got cost constraints, and everyone has quality expectations. But you have to combine all three of those things so that you can deliver a great product. And patient services in whatever format is exactly the same. So that's one of the essential mistakes that nurses often make, is that they feel like they can if you just look after the quality, the rest will come. But you can't. It's just like a fire triangle that you need all three for it to work. The next mistake is actually being a little blind to your environment, particularly as a lot of nurses grow into or fall into these senior positions or nurse managing positions where they're asked to step up and be the nurse manager for a period of time, and they act for 6 months, which turns into 6 years really, and then all of a sudden they realise they've been in the job for a long, long time, and they wake up one day and they go, oh, I'm actually a nurse manager. And that's often the way nurse managers grow into their roles. So that means that they've been working in the environment for a long, long time, and they don't often see the possibility of what can be achieved in their environment because they've been around it for so long. I'll give you an example and I'll give you the punchline at the end and then go back to the beginning. This is a story about a London hospital with 20 operating theatres. That's not an unusually large. I think most operating theatres are around 6 to 12, with the very large tertiary referral hospitals being larger. So it's not an excessively large operating theatre. It's a public hospital. And I think if you said to any nurse manager of an operating theatre in Australia that if I gave you $62,000 a week extra, what could you do with it? And I think they would be absolutely delighted. What you could do with $62,000 if they handed it to you and you could just do whatever you wanted with it would be a gift that would be absolutely unheard of. That's a 20 operating theatre hospital. So even if you're in a 10 operating theatre hospital and they said, I'll give you $30,000 a week and you can do whatever you want with it, they'd be talking about getting the waiting list sorted, stopping cancellations, not worrying about theatres going overtime. One of the things that nurses they can't cope with in the operating theatre environment is watching patients get cancelled, that they really thought they were going to get their cardiac surgery today, but the emergencies list went over and another reopen came back from ICU and this happened and that happened and you've got to cancel. And it's terrible. And they're the sorts of problems that as patient advocates really, really grind with who we are. So what you might be able to do with $32,000 would be unbelievable. So actually it was GE Healthcare that was asked to come in and do a review of this operating theatre. And GE Health had a look at their theatre utilisation. So one of the core metrics for an operating theatre is you have X number of operating minutes available to you and your utilisation of those number of minutes is 70%, 42%, 96%, whatever it is. But they've come in and they've reviewed the utilisation. And they discovered that only 1 out of every 4 of those theatres started on time. And they asked the management team of this operating theatre, how long do you think your theatres are running late to start on time? And their answer was, yeah, they sometimes don't start on time, but it's 5 minutes, no more, maybe 10 minutes, but generally they started on time. When GE finished that review, they found that it was 45 minutes. That 3 out of 4 theatres started 45 minutes late. And when they put that back to the hospital and said, it's actually 45 minutes late that you're starting these operating theatres. If you're starting and putting down that your theatre start at 8 o'clock and you're actually starting at 8:45, why not just make the list at 8:45? I thought about that for a while and then came back and said, actually, we realised that if we made it 8:45, then the start time would be 9:30. So there were some fundamental systems issues. So GE dug a little deeper and they found that there were some fundamental problems. One of the most significant problems here was that cancellations happened, so patients would self-cancel. The other problem was that when the pre-admission clerk took the bookings for the list, they just put them in whatever order they thought. And then the surgeon then would come in and go, oh, that's a terrible order. No, patient 4 needs to be first and patient 3 needs to be last and patient 4 needs to go second last, and they'd reorder the list. Then the anaesthetist turns up to the ward to see the patient number 1 and they go, oh, that patient hasn't arrived now because they've been now made the 6th patient. Now it's this patient. Oh, where's their ECG? Where's their bloods? Where's the patient file? Where's their x-rays? And it was a schmozzle, and every time the anaesthetist would turn up 42 hours late. Here's the part that is unbelievable. When they costed all of the nurses, orderlies, CSD processing time, the anaesthetist, the registrar, the surgeon, everyone, or the equipment at the hourly rate, everybody that impacted those 20 theatres that were running 45 minutes late, that meant the next list didn't start, people weren't getting meal breaks, there was overtime, sick leave was high because it was, people were working much later than they thought. It was $62,000 a week that they have lost time as a result. $62,000 that if they just started at 8 o'clock and not 8:45, then they would save $62,000 a week in lost time. Sometimes the answer isn't just throwing nursing hours at the solution. But if you're feeling understaffed and overworked, then throwing nursing hours isn't the problem. It truly is taking a look at what your environment is and taking a really blank look, taking a step back and not being blind to what you see. They thought they were 5 minutes late. They thought most of them started on time, a couple started 5 or 10 minutes late. 75% started 45 minutes late. But after all of that time, they were blind to that. So our next mistake is, and this is a really, really common one, it's believing the myth that there's no money. I think most of us feel like there's never any money. But I think we get that message. I think we hear every journal article that we read about nursing is about cost containment and about how we can be more cost effective. We hear about the ageing population, hear about chronic disease, we hear about the reform that's happening with private primary health care and out of acute care, and the core message is we need to do more with less. There's something pervasive about the fact that we grow up believing that there's absolutely no money anywhere to be had. And I think that feeling about escalating costs really, really do impact us. But here are some statistics that you need to really think about for a while about what our healthcare industry actually looks like. This country spent $172 billion on health in 2013. We spent 11% of our GDP on health. 53 billion of that was on hospitals alone. That's a lot of money. That is more money than anybody will see in a lifetime. I mean, it's more money than probably Brisbane put together. Then residents will see in a lifetime. It is an enormous, enormous amount of money. I'm not sure if you're familiar with the Da Vinci robot, but it is the latest and greatest thing in robotic technology that's performing a range of general, orthopaedic, gynecological procedures. It's an unbelievable machine. To get one Da Vinci robot into a hospital, it comes at a cost of $2 million. And what's unbelievable is you think, I don't know how many hospitals would have that. There are 2,000 Da Vinci robots in America. 2,000 hospitals have invested $2 million on one piece of equipment, one thing to do a select band of operations. This is emerging technology and it will grow and it will do more and more operations. But at the moment, I don't know what kind of number of operations that happen in operating theatre that it constitutes that it can do and do effectively. But I'd be surprised if it was 10%. I'd be surprised probably if it was 5% of the operations. It's a very, very niche part of the operating theatre. And the operating theatre is a very niche part of the whole health sector. Yet we will spend 2,000 hospitals will spend $2 million on one piece of equipment for a niche specialty or a niche function. That's America though, so that can be a bit different. But if you look at Australia, there's the new Royal Adelaide Hospital that's opening or might have opened. That hospital cost $3 billion. $3 billion. We spent $172 billion in total in 2013, but this hospital cost $3 billion. I had a look on a couple of websites, and there's a website, architectureanddesign.com.au. I haven't verified this statement that they've put in there, so it may or may not be true, but I'll read what they've written about it. Adelaide might not come to mind when we talk about places with expensive buildings, but a new hospital in the southern city has been named the third most costly project in the world after New York's One Trade Center and Bucharest's Palace of the Parliament, the only Australian project ever listed in the world's top 10 most expensive skyscrapers. Now, I don't know about you, but I would have put money on the fact that a hospital wouldn't be in one of the most expensive skyscrapers. Not when there are buildings like Marina Bay Sands and I can't remember that name of the Dubai sale building. But that is an unbelievable statistic. Even if they are completely false and it's actually the 40th most expensive building in the world, that's unbelievable for a hospital. The other thing is that this is a sector with the only growing sector in the country. 1 in 5 people by 2020 or maybe 2025 will be employed in our sector. So it is a huge, huge element of who we are and what we do. So don't believe the myth that the hospitals have no money, that the health sector has no money. It has a gargantuan amount of money. You just have to make a case for it. Now, that money is well and truly divided up. In fact, I went to a presentation this morning from the Director General, and when you see his pie chart about I'm the Director General Health and this is how I've allocated my budget, you can definitely buy into the fact that, you're really robbing Peter to pay Paul. But you guys are the clinicians and you know what X amount of money can impact on your patients and your niche patients. If we're spending $2 million on a niche number of surgeries, then surely if you're a midwife in the community or you're doing diabetes education, you could make an argument so well about how you could make radical impact to the healthcare of this country in management of chronic disease and acute care outcomes, because you know this stuff. You've lived and breathed it for years and years and years, decades probably. It's truly a case of if you can't beat them, you've got to join them. You've got to get on this bus about the fact that money isn't the evil and you need to ignore it. The money is where the outcomes are and where you can actually deliver a real change for your patients. And you have to embrace that. You have to be able to make a case. And that sounds really intimidating to nurses, like write a business case. How do I do that? There are so many things and ways that you can do that it's not funny. And the noisiest wheel gets the oil at the moment, because nurses aren't making a case about this and are believing the myth that there's no money. Then it's actually doctors who are making the case, and they make a case beautifully, and they're very, very noisy about it. And they get Da Vinci robots, and they get, loads and loads of operating theatres spend an enormous amount of money on their capital expenditure, because doctors are really effective at making cases. And they don't write a business case, they just make noise. But our case is a bit different, sure. Hospital reps, the healthcare reps that are selling devices, make exceptional cases, and they come in as salespeople, not clinicians, not really key doctors who make the hospital a lot of money with revenue. They're just guys that turn up and go, if you buy my X, that will mean Y for your patients. Nurses are much better positioned to be able to make that argument than reps. You just got to be able to know how to do it. Your hospital's, your greatest ally in this process is your hospital accountant. Now, a lot of the time I think nurses look at accountants and go, the bean counter. And I think they're pretty okay with that label. But the bean counter that has no idea about patients, that has no idea what it means to look after a patient, that sees patients as widgets on a conveyor belt. And they actually feel quite intimidated by this person that has a command over these numbers and spreadsheets and profit and loss. The fact is the accountants is intimidated by the clinical environment as you are by them. They actually don't understand it. They don't. They don't understand what it means to do X and how that means Y. So they need you just as much as you need them. And it's really important. It doesn't just have to be the nurse manager, and it doesn't have to be the nursing director that has the conversation with the hospital accountant. Anybody can come up to them and say, hey, I have this idea that we're using a lot of agency, but surely if we just used a permanent part-time person on overtime, would that be less expensive or more expensive than agency? They're delighted by that question. Absolutely delighted by it. They'll sit there and they'll do it for you, or they'll delegate it. They might delegate it to somebody else, but they'll come back to you with an answer of, yeah, actually, permanent part-time when you're doing your roster is actually cheaper than an agency. It may not be, but they actually are like Switzerland in the fact that they are not actually biased. They only believe numbers. They're completely logical people, and they believe data, and they're not swayed by a political stance of the organisation about what they think about agency or this. They just produce the facts. So it's really incredibly important to be able to use the resources that you have. And just like when you are new to nursing and you're delivering education and you think, oh, I'm a senior clinical nurse and I've got to deliver a education on, whatever, and it's not necessarily your key strength, then you find someone that does do it. You're going to present on wounds and you've done, a lot on this and that, but you haven't actually seen this kind of wound and, maybe you could get someone else to give you a hand with that part of the material. Nurses are great at getting access to other resources, great at finding other nurses to help them with that. But for some reason, we don't go outside our own nursing network, whereas there are heaps of people out there like accountants that can help you, but you've got to be able to really embrace that concept that there's not no money. It's not a case of there's no money. There's money. You just have to be able to build a case, find the resources, get a plan and be able to present it. So they're my top 5 mistakes that I think new nurse managers make. If you're needing more help with that, or you want to know more information, or you want to work a bit further, then you can go to this website. I've got a link there, Money Mistakes, my website, nursemanagerhq.com/money-mistakes. And I've got a whole load of templates and resources there for you to look at so that you can better understand how you might be able to use these principles and debunk them so that you can make a case and get great projects going.
Nicole, thank you for a very interesting presentation. I love certainly the catch cry of no margin, no mission is one that is, well heard within the industry. But I love the turnaround of margin sustains mission.
Yes.
I think that's a great little concept.
Yeah.
And just as, and I've worked as a nurse manager in a number of areas, but one of the things that continues to amaze me, and I'm pleased that you brought it up, because there is money in healthcare, but because the allocation of those resources is left to such a few individuals, they need to have a decision-making framework as to where the money goes, and hence why in order to be able to validate why they've spent the money, they need to have a compelling reason. And as nurses, I think for a long time, because we can see the need, we've assumed that everyone can see the need. And people become frustrated when they say, how obvious does it have to be? And they go into meetings for resource allocation and say things like, well, we just need it, or, it's obvious that we need it. Where the reality is, you need to be able to identify why you need it. You need to be able to articulate, and we do it between ourselves. We build fabulous business cases between ourselves, and you can, tick off the rationale and how it would save nursing time, or how it would, better meet the need of this patient group, or indeed stop the 45-minute delay, or, negate the need for the agency nurse. But we're hesitant to document, and we're hesitant to put it into a package that we need to sign our name to.
I think if the tea room could talk, there would be no need for anything else to happen, and the world would be run by that tea room, and great decisions would be made. Because I think you're right, we do spend time in the tea room talking about why X would be great for Y and what it would mean. One of the reasons I think nurses aren't reticent to put pen to paper is that we spend so much time developing critical thinking and clinical judgment skills that we can look at a patient and we can have a look at their history and make a determination about what trajectory they're going on and what needs to happen. And there isn't a lot of writing. In fact, documentation is such a burden to us that when someone asks us, well, what criteria did you use? What checklist did you use to determine that your patient needed that? There isn't one. So they go clinical judgment. We are so good at clinical judgment that when you have to actually unpack those thought processes, it is a very, very different skill set. And they're the things that are quite intimidating, or just counterintuitive, I think, more than intimidating.
And that's why we become so annoyed at the so-called bean counters, because what seems like such an obvious linkage that the frustration becomes palpable when you do have to unpack it for others. But the issue is most of the people that are held accountable for the allocation of resources aren't the nurses.
No.
So if a nurse wants to be able to, or if a nursing team, a nursing group, a nursing division wants to have a bite of those nursing resources in order to, create a much better system or unit, then we need to understand that we're not dealing with peers. We're not dealing with people who intuitively understand where we're coming from. We're dealing with people who know Jack. And it's up to us to be able to articulate what we know to be truth and what we know the result will be, but we can't just expect people to accept our word.
Yeah, I've spent many an hour sitting with accountants that when you start the conversation, their hands go up and they go, I don't know what happens with the clinical side. I'm just saying this is the maths. And after I'd been in that situation 4 or 5 times, I had that realisation that they that when you're dealing with $172 billion, you do need to have quite a framework and quite a justification around it. It's not just, well, I think we need a Da Vinci robot. Yeah, it's $2 million. Will it be good? Yep. Oh, okay. Well, that sounds good.
That's right.
That's never going to happen.
If you're going to be called to a Senate Estimates Committee as to why you spent $2 billion, you're not going to stand up and say, because that nurse told me to.
No, they're not even going to say,
Because
Dr. Bloggs thought it was a cracker and he was really excited about it. Excellent. No, moving on.
Because other people would look at you with, the level, identifying your level of incompetence being close to that of a gnat. They're not going to put themselves in the firing line, and that's where we as nurses need to understand it's not because there's no money. It's because we can't articulate our need adequately enough to be able to get a bite of that money.
No, and it's there. It's absolutely there.
So, and then what happens then is you go into a unit and they're dealing with either archaic equipment or their work processes are ridiculous. They're having to run down 2 flights of stairs to access a drug cabinet because, the architect forgot to put one upstairs or whatever. And it's eating into their time and, the frustration's palpable, or, you're in a bathroom where you're trying to provide hygiene care and you're getting caught up in shower curtains and all that sort of stuff. And a new person walks in and says things like, why are you putting up with this? This is just ridiculous. And the team that are there is, there's no money to fix it. There's no money to fix it.
No money to fix it. We really buy into that myth.
We do.
We really buy into that myth.
The reality is there's money to fix it, but because it's the same as when you're dealing with, interpersonal relationships in any situation, if you whinge or nag, you get nothing. You need to be able to, as a group, articulate what the issues are, identify what the consequence is, look at what the savings could be, and whack that down on a bit of paper and take it to every committee that's possible within that hospital.
Absolutely. There's a great story by that GE Healthcare presentation with the $62,000 a week, that the same hospital, when they were reviewing it, one of their problems was that they lost equipment, and then she said, why don't you just have on the whiteboard that the II machine's in theatre 4 or the laser is in theatre 6? And their answer was, we don't have a whiteboard pen. That was actually a genuine answer. And and the thing is that I've actually been in places where there's no stationery. The organisation is so tight on their stationery budget because it's an extraordinary amount of money that they get really, really, really obsessive. And then all of a sudden people buy into the myth like, we can't buy stationery. You can buy stationery. You just can't. You just have to argue the fact that, to argue that you need a whiteboard pen is beyond ridiculous, but you do buy into that myth of, we can't spend much on stationery. No, you can. You just have to be sensible about it. You just have to justify it. It's unbelievable.
Right. You walk into a unit and say, I've lost my pen. Where's a pen? Or we don't have any pens. Why don't you have any pens? Because we can't buy any stationery. All right, well, you're paying me $42 an hour, but I'll just waste 15 minutes of my time trying to find a pen. That's right, and I could have bought 400 of the things in the time it's taken you to spend that money on me to look for one.
But we buy into the myth there's no money. No, they're just really trying to use their resources correctly, and, you know, stationery is the case, but we just go, oh, okay, can't buy stationery. Bloody hell.
Yeah,
no.
I know. And so the aim is don't buy in, understand that there is money. We just need to be able to articulate the need for it.
Get on the bus.
Another example that's right. Another example is, like, you know, as you rightfully said, wages about 72% or whatever of you know, operational costs, and then you've got the other resources like stationery, medical supplies and all that sort of stuff. But, you know, you do have people that you're spending 72% of your operational budget on wages, but the resources are going into either saving the pens or getting people to save half the sachet of sugar. You know, because
we're spending against the lightning.
Yeah, and you know, and not only does that make you cross your eyes with, I can't believe people would do that, but the amount of time and energy it takes to actually get those punitive measures put in place. If you look at the hourly rate of the individuals who's putting those punitive measures in place, it's just false economy.
Absolutely. But it's just exactly like that operating theatre that, you know, just $62,000 a week spent while nurses stood around till 9 o'clock in the morning, and then were on overtime at the end of the day. And they would have been screaming out for health resources in terms of nurses. They just would have said, if you were given 100 more nurses, what could you do? They would just be like, oh my God, as if that would ever happen, you know. And it was there for the taking. They just needed to tweak. It was a tweak. It wasn't a restructure. It wasn't vast changes, tweaks. But they were blind to them because they were so used to it and so accepting of, well, this is what we do. We just wait for the anaesthetist to come. No one said, what's the anaesthetist doing? Running around looking for the first patient. Why is he doing that? Because we reordered the list. Who did the list? The readmission clerk. Right. Okay.
And it's that helplessness model, isn't it? Like, rather than being passive within and accepting within the process, being able to identify what the issues are and then grabbing the influence that you have to fix it.
Yeah.
Because as you rightfully say, the bean counters welcome the opportunity to speak to anyone who actually could be reviewing work practices.
Yes.
You know, they welcome the opportunity to say, that's fabulous. And most managers, most overarching managers don't come to work like Scrooge, working out how can I make the people who work for me, their life, any more horrific. They come to work knowing that, as you rightfully said when you identified the 10 issues that businesses operate under, they need to be able to pay their staff, they need to be able to pay their bills, they need to be able to get consistency of people coming through the door, because there's two ways to budget. You either react, so if you only get 2 patients coming in the door, then you cut your staff to meet those 2 patients.
Yep.
Or you proactively manage in that you try to get an even income stream coming in, and that way you're not having to cut people's hours.
Yeah, exactly.
But the managers are trying to manage. What they need is for their staff to be able to also take part in the process, and nurses do want the best for their clients, and they want the best for their colleagues.
Absolutely.
And they want to be able to have respect for their unit and pride in their unit. So I think we all come to the workplace. We just need to, I agree with you, don't believe the myth that there's no money. You just need to be able to articulate why you need it.
Absolutely.
Nicole, an exceptional presentation as usual. I would recommend Nicole's website, nursemanagerhq.com. There are some fabulous resources, excellent resources available to you on the website, and Nicole is available herself if you would like to take this learning opportunity further. So www.nursemanagerhq.com. There are some great resources there. Nicole, thank you again for a fabulous presentation.
Great. My absolute pleasure. It's been great.
To everyone who's listening, I wish you an absolutely exceptional day. And I look forward to seeing you on another webinar very soon. Goodbye.